All right, let's jump right into this explainer. We're breaking down two absolutely life-saving 2026 emergency protocols from the South Medical Ward over at Mayo Hospital, Lahore. We're going to look at the definitive algorithms for managing acute corrosive ingestion and acute pancreatitis. These are two incredibly volatile presentations where the ER is just absolute chaos, and literally every single minute matters. Having a structured mental framework in these moments, it isn't just helpful, it is quite literally the difference between life and death. But real quick, before we start the clock on our first patient scenario, I want to point out that this entire clinical guide is based squarely on the evidence-based work and protocols created by Dr. Amir Rana. The structure we're going over relies entirely on these carefully developed tools designed for both emergency and ward management. In the heat of the moment, protocols like these are what eliminate deadly guesswork. So here's our game plan for today. We'll cover the emergency room protocols, the initial response for corrosive ingestion, endoscopy and injury grading, diagnosing acute pancreatitis, and finally, those critical first 48 hours of pancreatitis management. Let's get right into it.
Part 1. The Emergency Room Protocols.
Setting the scene here, emergency medicine is intrinsically tied to the clock. Time dictates your options, your risks, and ultimately your patient's outcome. Our goal with this explainer is to take these complex flowcharts and turn them into actionable reflexes. We want to empower you to make the right call under immense pressure, completely moving away from guesswork and leaning into an evidence-based approach that minimizes error when things get chaotic.
Moving into Part 2, Corrosive Ingestion and our initial response.
Picture this. A patient just rolled through the doors after swallowing a corrosive substance. Those very first 0 to 2 hours, it's an absolute scramble to secure their ABCDEs: airway, breathing, circulation, disability, and exposure. You're hunting for stridor, drooling, or hemodynamic instability. If they're drooling or stridorous, the airway is already compromised. You intubate early and get them to the ICU immediately. Now, assuming the airway is intact, you move straight to the strict do's and don'ts. First, keep them NPO, absolutely nothing by mouth. Secure IV access to pump isotonic crystalloids and start a PPI, like pantoprazole at 40 milligrams to bring down stomach acid. But here is the crucial part, what you absolutely must not do. Do not induce vomiting. Don't use neutralizing agents, skip the gastric lavage, and whatever you do, no blind NG tubes. The tissue in their throat is actively dissolving. If you push a blind tube down there, you could easily punch a hole right through their esophagus and turn a critical situation into a fatal one.
So, as you're stabilizing, you need to actively stratify the risk. Spotting these signs early dictates your entire triage path. High risk means airway issues, shock, peritonitis, or any suspected perforation. Those folks go straight to the ICU, no questions asked. You're also watching like a hawk for urgent red flags: severe pain, hematemesis, vomiting blood, dysphagia, or persistent vomiting. On the flip side, if their vitals are stable and they aren't in any respiratory distress, they're low to moderate risk. They can safely go to the ward. Let that branching path sink in for a second, because that initial call sets the tone for everything.
All right, Part 3, Endoscopy and Injury Grading.
Now that the patient is stabilized, we need to actually see the internal damage. And this is a massive clinical trap because timing is literally everything. You cannot use an endoscope before the 6-hour mark. The patient is just way too unstable. Instead, you absolutely have to hit that 12 to 24-hour sweet spot to look inside. And perhaps the biggest takeaway here, never, ever scope during the 48 to 72-hour window. At that point, those chemically burned tissues are incredibly friable and weak. Run a scope down there during that high-risk window, and you're risking a catastrophic perforation. Once you safely scoped them in that golden 12 to 24-hour window, you use the Zargar classification to figure out your game plan. It's fascinating how drastically the care escalates here. For a mild grade 1, it's just supportive care, PPIs, and you can actually start them on early oral intake. But watch how fast things change. Hit grade 2B, severe, and suddenly they need the ICU, IV meds, and enteral feeding. And if it's a grade 3, that's life-threatening. The whole protocol flips. You're immediately getting a surgical consult, pushing broad-spectrum antibiotics, and prepping for TPN, completely bypassing the gut.
Section 4. Diagnosing acute pancreatitis.
Okay, let's switch gears to our second emergency scenario: sudden, severe abdominal pain. Acute pancreatitis is incredibly common, but man, it can turn deadly fast if you don't stick to the protocol. The beauty of this algorithm is in its simplicity.
To definitively diagnose it, you don't need a million tests. You just need to meet exactly 2 out of 3 specific criteria. Just 2. And here are those 3 criteria. First up, typical epigastric pain that radiates straight to the back. Second, serum lipase or amylase levels that are greater than 3 times the upper limit of normal. Just as a quick refresher, these are pancreatic enzymes, so when the pancreas is inflamed, they leak into the blood in massive numbers. And third, characteristic imaging findings on a CT scan. Now, think about how powerful this is on the floor. If your patient has that classic radiating pain and their labs show lipase is more than triple the normal limit, boom, you've met 2 criteria. You've got your diagnosis. You don't even need to wait for that CT scan, which saves precious time and resources so you can start treatment instantly.
Finally, Section 5, Pancreatitis and the first 48 hours.
With the diagnosis locked in, the clock starts ticking on those critical first 24 to 48 hours. This is your window to prevent systemic complications and organ failure. There are 4 consecutive steps you have to follow relentlessly. Step 1, fluid resuscitation. Goal-directed therapy with lactated ringers at a moderate initial rate. Step 2, pain control. Hit it with paracetamol or opioids, but absolutely avoid NSAIDs if there's any acute kidney injury. Step 3 is a real paradigm shift, nutrition. Forget the old advice of resting the pancreas. We now prefer early enteral feeding or low-fat oral diet if they can handle it, because keeping the gut fed helps maintain the barrier and prevents infection. And step 4, absolutely no routine prophylactic antibiotics. You only use them if an infection is explicitly confirmed.
Now, while you're managing the acute phase, you also have to play detective. Run your labs to find the etiology. Is it gallstones, alcohol? At the same time, you need to constantly be calculating severity scores like BizApp, Rancid, or Apache. You're not just doing this for the paperwork, you're doing it to anticipate organ failure before it happens, so you can trigger an immediate ICU transfer if they start to crash. And of course, keep a close eye out for local complications as the hours tick by, like tissue necrosis or pseudocysts.
But here's the reality check. Algorithms and flowcharts provide an incredible, evidence-based framework, but they do not replace you. The 2026 guidelines make a massive point of emphasizing that your clinical intuition is what ultimately guides these pathways. A flowchart simply can't evaluate the complex human being sitting in front of you. So, if a case deviates from the textbook, never hesitate to pull in your seniors.
So I'll leave you with this thought. How are you going to use these updated 2026 protocols to save a life on your very next shift? If you internalize these golden hours and lock down those strict diagnostic criteria, you won't just be reacting to the chaos of the ER tomorrow, you'll be commanding it. Thanks for joining me on this explainer, and good luck out there.